different societies, Heart Failure Society of America, Heart Failure Association of ECC, Emirates, Tunisian, Jordan, Lebanon, Kuwait societies. Again, thank you so much, Professor Beacom and Professor Scott Solomon, for accepting our invitation. We are delighted that you are joining us today. I'd like to welcome my co-chairman in this session. Today, we have Professor Mohammed Sobhi, the past president of the Egyptian Society of Cardiology and the governor of the ACC chapter in Egypt. Professor Ali Al-Atribi, past president of the Egyptian Society of Cardiology, chairman of the working group of interventional cardiology at the Egyptian Society of Cardiology. Professor Mahmoud Hassanin, past president of the working group of heart failure, professor of cardiology at Alexandria University. Professor Hani Rali, past chairman of cardiology department, National Heart Institute. Professor Muhammad Ramli, professor of cardiology at Cairo University. So I think we are ready to start the first session, and I'm inviting Professor Sobhi to introduce the first speaker. Professor Sobhi.
Okay, thanks, Professor Magdi, for this nice introduction, and congratulations for the wonderful Congress in such pandemic era. It's the very good hybrid meetings at 21 Annual International Congress, Egyptian Society of Cardiology Heart Failure Working Group. And thanks to all international speakers and national. I'd like to introduce the president of the Heart Failure Society. Actually, this is the second time for Beacom that we have all the Heart Failure Society to join Egypt, one of the CBRF, the second now in the Heart Failure Working Group with the Dr. Scott. Thanks again. I think we learned a lot from you. You are more experts, and we need a more interactive discussion. And thanks, Dr. Meg, you invite this wonderful group to be in this meeting. Dr. Beckman is the Mary and Gordon Gain, W, Tex, and Deborah Moncrief, the chair professor of medicine and the medical care line in the Becky, well known in Texas, the Becky Medical Center director. And also she's the associate of heart failure research, and also she is associate director of Cardiovascular Research Institute in the Baylor College of Medicine, Houston, Texas. Thanks again, Dr. Beckman, and I'm looking for also the interactive discussion in between the lecture. Beckman?
Thank you, Dr. Sophia and Dr. Magdi, and I really appreciate the opportunity to present and share our discussion. And just as a way of announcing our transition in the leadership at the Heart Failure Society of America, as of October, early October, when we had our annual scientific meetings, the new president is Nancy Albert, our first nursing president of the HFSA. So I'm the immediate past president, and I'm really privileged to represent my society along with my colleagues from USA. So the topic of my presentation is not a new definition, but a new recognition and a new classification that we're debating with heart failure with recovered EF. This is an entity that's well known to clinicians because we've been seeing this in the bedside. All of you have seen this with some of your patients. The question is what to do. And these are my disclosures. And if we look at our current definitions or terminologies we are using in the spectrum of guidelines, we have an overarching definition, and I'll go over that in a minute. Then we have these ejection fraction phenotypes, and now we also have an entity called the stages of heart failure. And if we were to examine the concept of heart failure definition using the guidelines, and as represented over here, I included the historical definition from the Heart Failure Society of America to ACC, AHA, and the ESC and the Japanese Heart Failure Society. The emphasis is in a clinical syndrome of symptoms and signs. So I call this the overarching definition. Then, because of probably the necessity of recognition of progression and also to emphasize prevention and recognize the risk factors, in 2005, ACC and AHA came up with the stages of heart failure and recognize there is an entity called stage A. Those patients with coronary artery disease, hypertension, diabetes, and a variety of other, now we're recognizing risk factors such as cardiotoxicity or exposure to injury, being in stage A, even when the patient is asymptomatic and without structural changes. Stage B, when the patient has structural changes, but no symptoms or signs. C is the symptomatic syndrome of heart failure, where most of the guideline-directed therapies apply to it, especially if the patient has HFrEF or reduced EF. And D, advanced heart failure requiring specialized treatment strategies such as ventricular assist devices or transplant or palliative strategies. And if we look at our current EF terminologies used in guidelines, there is some concordance, but a variety of differences. And I'm going to try to highlight the commonalities. I think we're pretty concordant about HFrEF, heart failure with reduced EF, but the differences are, if you were to look at the ESC definition represented in the left lower, ESC has an approach for a EF quantification accompanied with the biomarkers and or structural changes that are defined for the mid-range. So for low EF, they do not require biomarkers or structural changes, but for mid-range EF, which they define as 40 to 49, they require additional biomarkers and structural findings. And for HFpEF, they require, again, biomarkers and or echocardiographic and or other imaging findings. In the 2013 AHA-ACC definition in the right upper panel, we did have the reduced EF as less than 40%, less than or equal to 40%, and HFpEF and greater than or equal to 50%. But guess what? We had this concept of borderline 41 to 49, which is termed as mid-range in ESC, but we also had this improved EF. Somebody who had a reduced EF in the past, but then had with the GDMT an improvement of the EF above 40%. And Japanese heart failure straddled this and embraced the concept of improved as recovered EF in their guidelines. If we look at the spectrum, and you've seen this slide many times, there is a wide splay of ejection fraction in the syndrome of heart failure, approximately half being in the reduced, half being in the preserved, and somewhere in between a mid-range EF concept that straddles probably the both domains of REF and PEF. And what is the current definition for heart failure with recovered ejection fraction? And I will try to go over the working definition in a minute, but modest recovery of EF, that a resultant EF compared to baseline that falls somewhere between 40 to 50. It has been defined as with the abbreviations of improved or recovered, and some actually even categorize that as now it's in the PEF, heart failure with preserved EF category. So the terminology is different between improved, recovered, and borderline to PEF. But the most important thing that I'm going to try to emphasize is we need to probably be very cautious about recovered terminology, and we will understand that in a minute. And second, look at the etiology, because some of the etiologies are truly reversible and some are not. And the trajectory, not only in the EF, but the remainder of the structure in the ventricle. And if we were to look at what's the current evidence, and this is looking at the EF trajectory that has been characterized very nicely by Savarese and their group. Among patients that have had preserved EF, approximately 40% will demonstrate a decrease over time. And amongst those individuals with reduced EF at baseline, approximately 30% will have an increase. And those that are in the mid-range, 37% will demonstrate a decrease and about a 25% an increase. And of course, the composite endpoints of where the patient falls to upon change. If the EF increases, it's usually a good sign. The endpoints are better, but never as good as those who have remained as PET all along. So improvement in EF is a good sign. It is better than no improvement or reduction in EF. Reduction in EF is the worst. We know that in terms of trajectories. And if we look at prospective study profiles that have looked into this concept of heart failure with recovered EF, and this was defined as less than 45% at baseline in this study, and an increase to greater than 45% at 1 year, as can be seen, those who had recovered EF compared to those who remain in the PET or REF. Those who remain in the PET or REF with no changes had a better outcome in the long run. Very important study. From this presentation, if you are to remember only one thing, I would like you to remember the findings of the TREAD-HF trial. TREAD-HF trial looked at the concept of withdrawal of guideline-directed medical therapy in those patients with recovered EF in dilated cardiomyopathies. And if we look at who those patients were, the inclusion criteria are listed on the left side. Those individuals who had a diagnosis of dilated cardiomyopathy with EF less than 40% at the time of diagnosis, with subsequent recovery of greater than 50% in follow-up, along with normal LV, EV, left ventricular diastolic volume, along with resolution of symptoms in heart failure to a level of NYHA class 1, meaning asymptomatic, along with a significant improvement in NT-proBNP levels. They excluded a variety of diagnoses as seen on this slide. And as you can see, they really found a very clean group of patients. What they did was they stopped beta blockers, ACE inhibitors or ARBs, MRAs, and even loop diuretics, and looked at the outcome of whether there was going to be a further decline in the future in EF by more than 10%, or enlargement of the ventricle by more than 10%, twofold increase in NT-proBNP, or patients becoming symptomatic heart failure. And guess what? Those who had withdrawal of the treatment, shown by the red line in the Kaplan-Meier curves, of course, demonstrated a significant worsening of heart failure. And about 40% of the patients who had withdrawal of treatment reached the endpoint, primary endpoint of either becoming symptomatic or having decline in their EF and or enlargement of ventricle. So, in summary of the TREAD-HF, withdrawal of pharmacological heart failure therapy from patients presumed to have recovered from dilated cardiomyopathy, and mind you, this was a very scrutinous study of definition of recovered, even selecting the patients who didn't have any ventricular enlargement, along with improvement in EF, 40% had relapsed. And this whole concept resulted in attempts for standardization of terminologies, and this was done nicely by Jane Wilcox and her colleagues last year, actually in the past year, that was published in JACC, and they came up with a working definition of a terminology of heart failure recovery EF. But this is not a commonly and or uniformly or universally accepted terminology yet. We're still debating about this, and their working definition is EF less than 40% at baseline, more than or equal to 10% improvement in EF, and the second measurement of EF being greater than 40%. More importantly, in this document, they emphasize the necessity of continued guideline-directed medical and device therapy for those patients who demonstrate recovery, and that they should have a close follow-up because of high risk of relapse. And if we look at the concept of what we term as improved or recovered EF. And again, this is due to a variety of entities in remodeling. The ventricle, of course, can enlarge and demonstrate a decline in EF, but there are many features, not solely related to EF alone, but structural changes in the heart, as well as volumes, as well as, of course, the etiology of the heart, that are critical to take into consideration. If we look at the spectrum of who improves and why they improve, they may be improving because the patient was ischemic and we revascularized, or they had a valvular heart disease abnormality and we fixed the aortic stenosis or the mitral valve, or they had tachycardia-induced cardiomyopathy or viral myocarditis, or alcohol-induced cardiomyopathy, and recovered. And if we look at this whole spectrum, which is in the inner circle of this figure, the ones that are truly reversible at the myocyte level are only a few. If we look at the spectrum, the ones that are usually termed as reversible cardiomyopathies are tachycardia-induced cardiomyopathy, substance or alcohol is short duration of exposure, not lifelong. Some myocarditis, especially if they're not in the fibrosis phase, 50% of the peripartum cardiomyopathies may be stress-induced. But those with scar formation, ischemic, with evidence of structural changes, may demonstrate improvement, but not a cure at this myocyte level. So that is important. So this figure that they use in their publication creates a more holistic view of when you're considering recovered, please look at the other features in either imaging and in the spectrum to define how the ventricle looks. So it's just not like EF going from 35 to 45 or 47. That's not to probably be termed as cured. And if the ventricle looks enlarged and has evidence of other structural changes, one needs to be following these patients closely. And they came up with a closer follow-up structure of how open to do EKG, how open to perhaps do further imaging with echocardiography. Again, this is not necessarily a guideline and not necessarily evidence-based. And intuitively at the patient level, I individualize. Some of my patients, I do an echo in 6 months. If I feel, let's say, tachycardia-induced cardiomyopathy and we treated the underlying etiology, sometimes I may feel as if the underlying etiology was truly reversible and they recovered, to create a more prognostication, I may do another imaging study within 3 to 6 months' time. But I follow them clinically, and if they have symptoms, they may actually demonstrate further decline in their EF in the future. So currently, the simplistic way to categorize these patients are, yes, EF less than or equal to 40% being as reduced, 41 to 49 as mid-range, greater than or equal to as preserved. And those who are in the mid-range may have evidence of improvement, and we're sort of debating on the terminology to use, whether to call them improved or recovered. And we worry about the terminology of recovered giving a false impression to the patient as being cured, and or to the clinicians to back down. We do not want anybody to back down on guideline-directed management strategies for improved EF. So the concept of what to use in these domains, I think, will need to be individualized. And keep in mind, there's still, in this EF ROM shifts, those patients who have demonstrated improvement in the future will demonstrate decline. Those who are in the PET category will demonstrate a potential decline, and those who are in the HFrEF may demonstrate an improvement. And the standard deviations or the errors for intra-reader variability as well as inter-reader variability as well as time-dependent changes on EF are plus or minus 7 to 10% for EF categorization. So when we are that magic number of Y was more than 10% defined as a defining concept for improved EF or recovered EF probably relies on the standard deviations. and Dr. Solomon and their group, being a core lab for reading EF over time, recognized that we sometimes round up these. As you can see from the top cat, they were rounded up to the multiples of 5, usually creating this concept of uncertainty in precision of EF quantification. So in summary, there is significant migration from one EF category to another over time, and that may be related to the variability in EF quantification as well as biological changes, but the true reversibility or cure in heart failure is rare. The mid-range EF appears to be overlapping between heart failure with reduced EF and heart failure with preserved EF, and is a dynamic concept. Multiple EF measurements are needed to distinguish between mid-range EF, persistent mid-range EF versus recovered EF. And though recovered EF portends a better prognosis, patients are still at high risk for future clinical events, and how much true recovery, clinical recovery meets this definition is unclear at this point. The only thing that we're certain about is guideline-directed management, meaning medical as well as device therapies should not be withdrawn and should be continued in those patients who demonstrate an improvement in EF. Thank you.
Thank you, Vikman, for this wonderful lecture. I will start the question. As you know that regarding the ejection fraction, this is a numerical part of the heart failure, as we discussed before in different webinars in these 6 months, that you should have what's known as the longitudinal global strain pattern. LG is important in differentiation rather than ejection fraction, because as you know, it's one by one, and so they are translated from mid-range to recovered to then preserved and then back. So, and I think Scott will have this in his talk. So how can we make it? We need measures patient per patient himself, or you think that we need 2 measures for one patient, or you should have a scoring for improvement, because you are not dependent. You have a table that's showing that you have a clinical ECG biomarkers and so on and so on and so. How can you make it into terminated in the score?
This is how I see it, Dr. Supi. This is a critical question. The global strain is actually very important in the pre, at the injury, at the initial level before even the whole syndrome develops of heart failure. We're seeing it in cardio-oncology, we're seeing it in cardiotoxicity. We are using it in the subclinical structural abnormality development. So in the stage B, those who are at risk, let's say, who are we going to use the cardioprotective agents in? Global strain is a very critical one to define what's happening to the ventricle even before the EF drop. So I'm actually embracing the global strain as both a higher sensitivity to declare the functional abnormalities in the heart, even before it becomes apparent before the EF declines in individuals that are high risk. On the other side of recovery, those individuals who recovered, first thing I want to say is, keep in mind, there's no such thing as full recovery unless the cause was truly reversible. So that's a clinical definition, right? Second, when you want to tell, and this is more of a patient customer service discussion, and because the patient always asks, has my heart recovered? In the setting of a recoverable cause, let's say tachycardia-induced, stress cardiomyopathy, peripartum, alcohol, right? In that patient, if the EF looks normal, size looks normal, the strain at that point is a very nice, sensitive, again, attestation whether the recovery happened at a higher sensitivity level. Now, I see the global strain as a complementary concept. EF by itself has never been a good contractile definer by itself. It's load dependent. And when I look at the EF, I always look at the volume. And I look now with the global strain in addition to EF and the volume. So I see it as a complementary when I'm looking at the EF, but I'm also looking at it as an independent feature when the EF looks normal and the volumes look normal. Scott?
Yes, I have a question. Thank you for your great presentation, Dr. Beacom. Can we extrapolate this concept of recovered cardiomyopathy to patients with malignancy who receive chemotherapy and is recovering from heart failure? And again, can we extrapolate? Yes, chemotherapy induced cardiomyopathy.
It's a very tricky balance. There are certain chemotherapeutic agents that have cumulative, adriamycin related cardiotoxicity, and sometimes evidence of fibrosis at the level of higher level of imaging. But we also straddle the necessity of having to treat them for their cancer, right? So that very delicate balance of risk-benefit ratio. We want to be able to give them the chemotherapy. So I think the concept is individualized both in a multidisciplinary manner. Yes, redosing for a life-saving therapy, we crudely look at the EF and say, yes, give the chemotherapy to save the life. But at the same time, continuing the GDMT, guideline-directed medical therapy, let's say we assume that the patient had Herceptin, which tends to recover more than adriamycin, right? At that point, the ventricle looks good, the volume looks good. Do I need to come off the beta blockers and or ACE inhibitors? At that point, I would look at the ventricle a little bit more closely with global strain and other concepts to make sure there is no subclinical as well as sub-recognizable abnormality. So the global strain, for me, is very valuable at that point to say this was reversible. So yes, I agree with you. It's very important in cardio-oncology, but individualized.
Right.
Okay, thank you very much for the excellent talk. Actually, I want to look at it the other way around. I mean, you should continue on guideline recommended therapy, okay, but guidelines are changing. So, I mean, if a patient having an ejection fraction of 36 or something, and it jumps to 40 after a few months of guideline-directed therapy, not including SGLT2 and not including sacubitril valsartan. So what would you do? Would we improve better? I mean, it's a partial recovery, so we have to give all guideline-recommended therapy to have the best result, or as long as
so absolutely. There is data right now that argues for continuation of optimization in a more comprehensive manner. Persistent low, 36 is low. Anything less than 40 is quite low. It's in the HFrEF. At that point, there needs to be further optimization of guideline-directed therapy because if you look at the HFrEF definition, history of or current symptoms of heart failure, right? So in that setting, the new armamentarium of life-saving therapies applies to individuals even with history of. So if your patient was stage C, meaning symptomatic heart failure, let's say 6 months ago, and then you did beta blockers, diuretics, ACE or ARB, and now they are EGYHF class 1. That's still stage C HFrEF. And the new guidelines with the armamentarium that we have with the SGLT2 and ARNI, SGLT2 inhibitors and ARNI would apply to that patient. And yes, we should optimize and do not assume stability. Stability is this concept of, the patient is stable with EGYHF class 2 or patient used to be symptomatic and now better. They still have a very adverse outcome in terms of mortality. And if optimized, they are getting better. And if you look at the DAPA, if you look at the EMPEROR, and if you look at the ARNI data, EGYHF 1 and 2 still further improve with the addition of these new agents.
Yeah, so it's very important to clarify this. So I mean, we can add to the summary or improve guideline-recommended therapy, not just to continue. We might even improve.
Absolutely.
I think we have to move now to the next speaker. It gives me a great pleasure and honor to be representing Dr. Scott Solomon. He is the Edward Distinguished Chair and Professor of Medicine at Harvard Medical School. He's also the Director of Non-Invasive Cardiology and Senior Physician at Brigham and Women's Hospital in USA. And he will be talking about the same direction with heart failure, with preserved ejection fraction, which a misunderstood disease in search for therapy. And I'm very glad to be sharing, co-chairing this session. I'm very honored to present to you, Dr. Scott.
Well, thank you very much for that very nice introduction. And I'm really honored to be here, especially on this panel with such distinguished panelists. And I do regret that I'm not with you in person. This is the second time in the last few months I've quote unquote been to Egypt and haven't gotten to see the pyramids, except in the nice pictures behind one of the panelists. So I'm hoping one day we will get to meet in person again. I'd like to follow on what I thought was an absolutely fabulous lecture by Dr. Gross to talk about what I call misunderstood disease, but I think maybe syndrome is a better term than disease, in search of a therapy. And the more I learn about heart failure with preserved ejection fraction, the more humbled I am. The more I realize I don't know. Here are my disclosures. And let's start with a definition of heart failure that works across the full spectrum. The inability to provide adequate cardiac output to the body at rest or with exertion, or to do so only in the setting of elevated filling pressures. I start with this because I think it reminds us that we are talking about a clinical syndrome, heart failure, that is characterized by these things. If you don't have elevated filling pressures, you probably don't have heart failure. We are hearing a lot of noise, and others can go on mute. Now, we know clinically that is a clinical syndrome characterized by breathlessness, fatigue, and an edema caused by an abnormality of the heart. And I say an abnormality of the heart because there are other things that cause breathlessness, fatigue, and edema, and we have to be able to make this distinction. It wasn't such a long time ago that we started to recognize that patients could have this syndrome of heart failure with relatively preserved or even normal ejection fraction, and we now clearly recognize this phenotype. The patient on the left, of course, is the HFrEF patient that we've been hearing about with the dilated dysfunctional left ventricle, and the one on the right has a essentially normal looking ventricle. You would not be able to look at that echocardiogram and quickly realize that there is a problem with that. By the way, I'm still hearing a lot of noise, and everybody can go on mute. I think it will be better for the audience. Now, Dr. Boskert has already shown a variation of this slide. Depending on how you define it, where you put that cutoff, between 30 to 50% of patients with heart failure have ejection fractions that are in the preserved range. Now, what I mean by that at this point in time is simply anything that isn't reduced. And I'm making that distinction because of the fact that we have good therapies for heart failure with reduced ejection fraction, and we don't yet for HFpEF. But these patients have the same signs and symptoms for the most part as those with HFrEF, with the exception of an S3 and cardiomegaly. They have edema, orthopnea, PND, rest dyspnea, crackles, elevated JVP. And the prevalence of this disorder is going up, especially in the United States. Now, one of the problems, I think, is that we believe for many years we understood what caused this disease. We thought it was diastolic dysfunction because we knew that systolic dysfunction was the problem when ejection fraction was low. And of course, we've seen that patients with heart failure, preserved ejection fraction do have evidence of diastolic dysfunction. Their pressure volume curve is shifted upwards and to the left. The problem is that diastolic dysfunction is absolutely ubiquitous in elderly patients. And so these are some data from my colleague Emil Shah from the Atherosclerosis Risk and Community Studies, where we looked at patients who were elderly but healthy, no diabetes, no hypertension, no heart failure, no coronary disease. And guess what? They have a very high prevalence of diastolic dysfunction, not as high as the patients with HFpEF, but it's definitely elevated. We can't claim that diastolic dysfunction is the reason that the patients over here have heart failure, and these patients are completely healthy elderly individuals. It doesn't make sense. So we and others have gone back and looked at systolic dysfunction in a way that is more sophisticated, just as was mentioned by Beacom a few minutes ago, using myocardial strain imaging, which is less load dependent and I think more robust than ejection fraction. And we start to see abnormalities, especially of longitudinal function of the heart, way before we see abnormalities of systolic function in terms of ejection fraction. And in patients with HFpEF, we've now shown this in many, many studies, their global longitudinal strain is reduced, their circumferential strain is mildly reduced. Interestingly, in patients as they progress from hypertension and diastolic dysfunction to HFpEF, their longitudinal strain gets worse first, and their circumferential strain compensates to keep the ejection fraction in the normal range. But ultimately, that compensation begins to fall off. Now, we don't see abnormalities of strain that are anywhere near what we see in patients with HFrEF. But still, the idea that that a measure of systolic function is an important factor in HFpEF is really interesting and important. And in fact, in the TopCat study, we found that global longitudinal strain was the single best predictor of outcome in these patients with heart failure preserved ejection fraction. We also like to believe we understand what causes this from a molecular level. I'm here to tell you we don't. At least we don't know definitively in all of our patients. There have been many really good theories, including dysfunctional calcium handling, abnormalities of the spring-like titin protein, the longest protein in the body that serves to restore the sarcomere to its resting length. And we know that diseases like diabetes and hypertension cause extracellular fibrosis, which reduces ventricular compliance and shifts the pressure-volume relationship. The most current concept in heart failure preserved ejection fraction, which is very appealing, but for which there isn't a tremendous amount of data, is that comorbidities like obesity and diabetes and hypertension lead to systemic inflammation, which causes a generation of reactive oxygen species and a subsequent depletion of available nitric oxide with a reduction in cyclic GMP, reducing phosphokinase G, which we know is potentially responsible for the development of myocyte hypertrophy and stiffness. It's a wonderful concept, and I can't tell you that this is actually what causes heart failure preserved ejection fraction, but it's certainly one of the current theories. Now, with respect to therapy, we're truly between a rock and a hard place with this entity. And if you look at the latest clinical practice article from the New England Journal written by Maggie Redfield, it's really empiric therapy. Consider alternative diagnoses, treat symptomatically, decongestion with diuretics, lower blood pressure. And there's pretty good evidence that from blood pressure trials that if you lower blood pressure, you will reduce the incidence of heart failure. Whether this is actually going to be beneficial in patients with heart failure is not as clear. Treat other comorbidities. Certainly rate control patients with atrial fibrillation. Many of us, myself included, believe that maintaining sinus rhythm is probably beneficial in patients with atrial fibrillation, but there have been no definitive trials of this as of yet. Diagnosing and treating ischemia, of course, because some patients with ischemia mimic HFpEF. And then when you get to the end of the rope, we have some therapies potentially. Now, the trials that have looked at HFpEF have all been, I don't want to use the term failed, because that really doesn't do justice to these studies. None of them have yet made their primary endpoint, but many of them actually came quite close. Candesartan with Charm Preserve came pretty close. Spironolactone with TopCat came pretty close. And if we look at TopCat in particular, we see that if we take out the patients who we didn't think had heart failure from Russia and the Republic of Georgia, where the event rates were much, much lower, we actually see a really decent hint of benefit in the patients enrolled in the Americas. Again, this is a post-hoc analysis after it was recognized that there was a problem with these patients, but still, I think it is very suggestive. Now, we had been studying for many years sacubitril/valsartan, first in the Paradigm trial with HFrEF, and you're all familiar with that, and then in HFpEF. And of course, sacubitril/valsartan is a neprilysin inhibitor, AT1 receptor blocker combination, essentially, and we block both the renin-angiotensin system and augment the naturally occurring vasoactive peptide system, including the biologically active natriuretic peptides like AMP, BNP, CNP, as well as a whole lot of other vasoactive substances that might be important in the overall benefit. At the same time we designed Paradigm, we had designed a phase 2 trial in HFpEF called Paramount, where we were able to show in 300 patients that we could reduce NT-proBNP, which is still a good marker of the severity of heart failure, even in the setting of neprilysin inhibition, because it's not a substrate for neprilysin. We reduced left atrial size, we improved New York Heart Association class. This is still the only positive phase 2 trial in heart failure, preserved ejection fraction. And we went on to design and conduct the Paragon trial, where we randomized patients to sacubitril/valsartan or valsartan. To get in this trial, they had to have an ejection fraction of 45% or greater, elevated natriuretic peptides, and evidence of structural heart disease. And the primary results, which I showed at the ESC last year, you've seen event rates of 14.6 per 100 patient years in the valsartan group and 12.8 per 100 patient years in the sacubitril/valsartan group, with a rate ratio of 0.87, 13% reduction, but the upper confidence interval just crossed 1 with a p-value of 0.059. Now, the benefit that we observed here was all based on heart failure hospitalizations. There was really no effect whatsoever. It went in the right direction, but certainly nothing much for cardiovascular death, but a 15% reduction in heart failure hospitalizations. And if we look at some of the secondary outcomes, we see the totality of data pointing to a biologic effect, that there is some benefit here. The patients on net improve New York Heart Association class, more patients improve, fewer patients worsen, with a 45% increased odds of improving the New York Heart Association class. There was a greater improvement in response of 5 points or greater in the Kansas City Cardiomyopathy Questionnaire. We saw a 50% reduction in worsening renal function, defined as reaching end-stage renal disease, renal death, or a 50% or more decline in GFR. There was no effect at all on all-cause mortality. Now, it gets really interesting in Paragon when you look at the subgroups. Normally, we think of subgroups as a way to look for consistency of a result. But in this case, we're convinced that there was true heterogeneity. This holds up to multivariable multiplicity adjustment, where we see two subgroups in which there is greater benefit in one than in the other. First being women derive greater benefit than men, and people with ejection fractions below our median of 57% derive greater benefit than those above. Let me look at that a little more closely. Here you can see quartiles of ejection fraction, and you see that the patients in the lower ejection fraction groups derive better benefit, and that attenuates as EF goes up. We can look at that together with the combined results from Paradigm. Now, had we done these two trials as one big trial, what we would have seen was this, which was every single endpoint would have been highly statistically significant and positive. Heart failure hospitalization or cardiovascular death, heart failure hospitalization, even in all-cause mortality, would have been significantly reduced had this been one giant trial. We didn't do it that way, although we did pre-specify that we would pool these data at the end of the studies and put them together. When we do that, however, we still see this gradient. So we see benefit in the low EF patients, the patients who were from Paradigm, and the lower range in Paragon, and then we see virtually nothing, basically no benefit whatsoever in the patients who have ejection fractions above normal. Look at that continuously, EF on the x-axis, the treatment effect on the y-axis. You see a diminishing of benefit as you get into that normal range. Now, I told you that men and women appear different as well. Well, it looks like their curves are shifted. So both men and women have attenuation of the benefit as ejection fraction goes up, but women, interestingly, derive greater benefit than men to a much higher ejection fraction. I wish I could tell you I understood why. Women do have higher ejection fractions, especially elderly women in that in the normal range, but I'm not sure we still understand the biology of why we're seeing a difference here between men and women. What we have learned, though, I think from several of these studies, is that one size might not fit all. HFrEF is clearly etiologically heterogeneous. There are lots of reasons for it: ischemic, genetic, viral. It's phenotypically heterogeneous, but it's therapeutically homogeneous. We treat HFrEF with beta blockers and ARBs and ACE inhibitors and ARNIs and MRAs and now SGLT2 inhibitors. HFpEF, however, is also heterogeneous etiologically, phenotypically heterogeneous, but I think it is therapeutically heterogeneous as well. And I suspect we're going to be paying a lot more attention to that in the future. Now, back to what Bikram was talking about, these ranges that have now complicated things, and I take some of the blame for this because Carolyn Lamb and I wrote a early paper talking about the middle child and heart failure mid-range ejection fraction in 2014. We didn't expect the ESC to create a whole new category, and I'm really not into these categories because I think that, as we just talked about, defining things based on ejection fraction, which has a plus or minus 5, 7, or even greater range, is problematic. But if we look at this range of patients in CHARM, in TopCat, and in Paradigm and Paragon, we see the exact same story. That is, these therapies, which by the way are all neurohormonal modulators, they do appear to benefit patients in the mildly reduced range similarly to the way they benefit patients in the reduced ejection fraction range, those patients we've been treating for all these years. So it makes me think that our arbitrary definition of of heart failure with reduced ejection fraction of 40% or less, unfortunately, probably pushed us into a corner and created this sort of therapeutic wasteland. Had we defined HFrEF as below normal many years ago, we might have helped many more patients. And we need to really reconsider this concept. Lastly, there are ongoing trials. We're continuing to try to figure this out. There are 2 trials going on with SGLT2 inhibitors, Emperor Preserved, and I'm leading the Deliver trial. These trials are both fully recruited, so we should have results relatively soon. There's a trial of a intra-atrial shunt device that equalizes pressure between the left atrium and the right atrium. There are several other trials with spironolactone going on. We just started the Fine Arts trial with a non-steroidal mineralocorticoid receptor antagonist, finerenone, which is based on the concept that we studied in the TopCat trial, thinking that an MRA could be beneficial in patients with HFpEF. In the end of the day, we are still desperate for definitive evidence-based therapy, but I think we've learned an enormous amount in the last few years about this disease, this syndrome, And I'm really delighted to have a chance to chat with you about it, and happy to take questions now. Thank you very much for your attention.
Thank you very much, Professor Scott Solomon, for this highly informative presentation. I have a question regarding Paragon heart failure trial. Some analysis which revealed that the use of sacubitril valsartan was associated with a significant reduction in biomarkers of myocardial fibrosis, like ST2 protein, tissue metalloproteins, and others. However, this was not translated into a beneficial effect of the drug in patients with HFpEF. And the second point, the importance of the post-hoc analysis of paradigm regarding the effect of sacubitril valsartan in relation to a proximity to hospitalization for heart failure, that early initiation of the drug less than 30 days is associated with the benefit compared with later use of sacubitril valsartan. Can you highlight these 2 points regarding Paragon heart failure?
Sure. So first of all, I think we have to move away from thinking about these trial results as binary, because they aren't. If we had had 7 events on in one group more than the other in Paragon, the p-value would have been under 0.05. This trial was clearly, in retrospect, slightly underpowered for the overall treatment effect. And it's probably was underpowered because some of the patients benefited and others didn't. And we probably had assumed incorrectly at the beginning that we would be able to benefit all of the patients. So I think that the data from the biomarkers are consistent with the outcomes data in Paragon. And in fact, we've seen in both Paragon and Paradigm reduction in several biomarkers, collagen markers, markers of fibrosis like ST2. Certainly both of them showed reduction in high sensitivity troponin and natriuretic peptides. That is clearly translating to benefit in the low EF range, in the reduced range under 40%, and in the mildly reduced range. It is not translating to benefit in the normal range and higher. Why that is really interesting, and whether these are patients who have another disease like amyloid heart disease or hypertrophic cardiomyopathy, we have to obviously consider that, but it's definitely possible that it is phenotypically a different group of patients. With regard to your second question and the patients who were most recently hospitalized, they did derive greater benefit. They also have the highest event rates. And there may be a couple of reasons for this. One is that they may still be in a congested state, and this is a drug that we believe does improve congestion in patients who have elevated filling pressures. The other reason is that we can be more certain that those patients truly have the entity that we call heart failure. And it may just be that, it's a better way to identify patients who truly have heart failure. We did have patients who were enrolled in Paragon who never had a hospitalization for heart failure. And clearly the patients who had a hospitalization for heart failure seem to derive greater benefit.
Scott, you have in one slide, one of your slides, the hypothesis of inflammatory mechanism of preservative, which is, I think, this is new for me. Do you think that it's time to start a study on anti-inflammatory, like the atherosclerosis? They started inflammatory, anti-inflammatory, and they proved themselves. So it could be this. Already we don't have the best treatment. We are trying to solve the problem in sub-study, but we don't have the actual mechanism. I think it's time for you and all the group which need this in a randomized trial. What do you think?
Many people may not agree with me on this, but the problem here is that many of the diseases that we know to be precursors of HFpEF, diabetes, hypertension, they are associated with increased inflammation. That's very clear. So the extent to which this is causal versus a epiphenomena is not clear. And if it is causal, which I'm willing to admit might be the case, the likelihood is it's a process that occurs over many, many years, probably decades. And so the likelihood that we can take someone with full-blown disease and then treat them with an anti-inflammatory agent like, for example, canakinumab or something like that, and reduce their likelihood of having heart failure events, I think is pretty low. Now, there are some data from the CANTOS trial that are marginal, I think, suggesting that maybe there is a hint of a benefit in terms of heart failure hospitalization, but I don't really buy it. I think that in the patients with full-blown disease, we're going to need therapies that are more directed pathophysiologically. However, your idea about heart failure prevention is fascinating, and many of us have been thinking about ways in which we might prevent the progression from what Dr. Bosker calls stage A and B heart failure to the full-blown entity that people like us treat. We do need to think about how to do that.
And if I can add to that, if you all recall, we have tried the anti-cytokine or anti-tumor necrosis factor alpha and IL-6 way back about a decade ago in the Renaissance and Recover trials in patients with HFrEF, heart failure with reduced EF. And with those agents, TNF receptor antagonists as well as decoy receptors, etanercept, resulted in some trend for adverse outcomes with increased hospitalizations. And in the post-market analyses of rheumatological agents, actually FDA recognized increased heart failure events with etanercept, and there's now a package insert. So with the canakinumab concept that is seen in post-MI, the benefit in IL-1 beta antagonism, there appears to be a significant benefit. So is it a different anti-inflammatory effect or different timing? Because there's definitely this concept of when is it maladaptive? Because we need inflammation to heal an injury, right? And if you don't have any fight to repair, then in the animal model, all these receptor knockout animals die. If you don't have any inflammation and if you have injury, you cannot heal the injury. Then comes the issue of when does it become maladaptive? So you don't want to abrogate these things long term when you don't need the tissue repair and they become maladaptive and evidence of oxidative stress. So when, which model, and what cytokine or what inflammation is, I think, going to be very critical. And right now, we don't have that much of evidence to be able to tell us, oh, it's IL-1 beta versus IL-6 versus TNF. TNF and IL-6 have been tried and failed.
Thank you.
Can I ask a question?
Yeah, Dr. Hani.
Thank you, Dr. Bosker, Dr. Solomon. This was wonderful, and thank you very much, Dr. Magdi, for giving us a chance to interact with key opinion leaders. I work in a public hospital with 1,000 patients a day, and I was just going to ask a very basic, probably stupid question, but it comes from the ground upwards. One of the things that we face is the ejection fraction. In Egypt, we have no echo techs, so everybody who performs echo is some cardiologist, usually a very junior one, and they don't even attach the ECG electrodes. I've actually done a little survey. 0% of Egyptians having an echocardiogram have the ECG electrodes attached to them while the exam is being done. All ejection fractions which are estimated in Egypt are observer eye ejection fractions. So those people go and they see a top gun like Magdi Al-Hamid, who looks at the EF and says it's 40, and then they tell you the EF is like 43 or 37, when they haven't actually measured it. So in my hospital, I have a real problem. I have patients with clinical heart failure who come with an EF of 37, and 2 weeks later they have another echo somewhere else which has an EF of 58. And the patients think they've improved, or it's the other way around, and think that it's worse. We have a real problem with ejection fraction. And I saw one of the diagrams you put, Dr. Solomon, which had automatic ejection fraction detection. Obviously, when that comes, AI will solve the problem of incompetent humans. But till that happens, and I know that echo is irreplaceable, it's just so easy, blah, blah, blah. But shouldn't each heart failure patient at least get one CMR or MUGA or one way of measuring the EF, which is not operator dependent? Does anybody, do you in the States face this problem? Because you have echo techs who are very dedicated, who are actually much better at doing echoes than cardiologists. But we have a real problem. We can't rely on EF in Egypt. Let me put this broad statement, and I ask my Egyptian colleagues to challenge it. Thank you.
You bring up a very interesting problem. This sounds like what happens when I do my own echocardiograms. And you're right, we have very qualified technicians. But even a great technician can't make up for the problems with the modality itself. And I think echocardiography is quite good, but you can easily misinterpret the ejection fraction, even in the best hands, even in a core lab, because this is a two-dimensional technique that is assessing a three-dimensional object. So it's inherently going to be limited. On the other hand, we often do know enough information to make clinical decisions. And for years, I ran our echo lab at Brigham and Women's for 20 years. And for years, we resisted even giving a number until we were forced to. We said severely reduced, moderately reduced, mildly reduced, or normal for many years there. And that's because even if we measure it, I don't believe we are doing justice. We did an experiment in our core lab where we took patients whose ejection fractions were between 40 and 50%, and we sent them right back in the core lab, the exact same studies, and 40% of them then fell outside that range of 40 to 50% in a very well-controlled environment. So one is we shouldn't make decisions solely based on those numbers. Two is I am hoping that we're going to get better both at estimating ejection fraction, and AI will help, but also perhaps using more robust methods like myocardial strain, which I think are really better than volumetric approaches like ejection fraction for looking at cardiac function.
And I will add to Scott's very eloquent, perspective and the presentation. I think he touched on all the concepts. The other thing that I do, in the event that I know my lab in certain domains is not to the level of precision that one envisions. So, for example, at several hospitals that I work at, we have a hemodynamic echo in one of the hospitals, and the other one has more of a robust portfolio in quantitative or qualitative, as you stated. And for example, in patients with emphysema, we resort to some other imaging modality. But I also do know in one of my other hospitals that I work at, the nuclear imaging is not as precise with maybe the background imaging normalization. So what I'm trying to say is, I think knowing your local regional differences, you can strategize knowing which one is strong and which one is with limitations. And the other portfolio that's rapidly developing is these handheld echo devices and other providers other than cardiologists. Like right now in the US, hospitalists are doing bedside echo, intensive care unit specialists are doing echo to look at the qualitative, whether the earflux or the pericardium show certain features. So I think we'll embrace AI, we'll embrace, longitudinal strain, and we will have these hemodynamic echo labs, plus the small little gadgets that's going to give very crude qualitative, and then all of the above will need to be able to, as cardiologists, see how we're going to embrace them and define further imaging.
Thank you. I'm holding a GEV scan in my hand. I don't know if you can see it on the screen. which has automatic EF detection, and I use it. I'll tell you what we did in 1 minute in my hospital to overcome this EF business. When we used to get, I'm an older guy, so when we used to get left ventriculograms on angio, everybody in the room, everybody in the heart team could see it. So if you showed people a left ventriculogram and you said this is an ejection fraction of 60 and it was 30, everybody in the room would say blah, bull. It's not. But people, we don't get that with echo. Why don't we get a live image? Why don't I get a little flash drive that I can stick to my computer and see the ventricle contracting? That would totally eliminate, wouldn't totally eliminate, but would to a large degree reduce the observer eye human error, because then I have my observer eye as well. And my recommendation is for echo reports, now that we're in a digital world, we include a video of the left ventricle. I mean, I don't accept echo reports on a piece of paper.
We have that. I mean, we can see our echoes in our hospital. So when we get a report, we can click and see the picture. So it can be very helpful.
Can I suggest a new for the American Association of Heart Failure? And you have the big database of heart failure all over the world. And now we are in the era of data mining, artificial intelligence. I think we have to reclassify the heart failure into other categories, phenotyping rather than the ejection fraction. If you got an old database and put it in your mind with the European, American, maybe the Middle East, and then you collect it and put it into scores, I think we will reach another classification rather than ejection fraction and the kill training. Because already we are depending on numbers, so I agree with Hani that it's very difficult depending on one country to others. We are in the era of the digitized medicine, and we are in the era of database collection, and I think you can suggest your association this and with the European, because we don't have this database like you. So you have to think about like the anti-inflammatory suggestion. Another suggestion of AI, I think it needs to be treated in the next 5 years.
Okay. For the sake of time, thank you very much, Professor Scott, for this excellent presentation. We have to move for the last speaker in this session. Mahmoud Hassanein will introduce the last speaker.
I have the pleasure to introduce Professor Nabil Farag, my dear friend. He is chairman of cardiology department in Shams University, and he is one of the greatest interventionists in Egypt. Dr. Nabil.
Thank you very much, Dr. Mahmoud, for this nice introduction. And I'd like to thank Dr. Magdi Abdelhamid for this great meeting. And it's my pleasure to be here chairing this important session with Dr. Scott and Dr. Beckham. My presentation today is about the management of heart failure in patients with valvular heart disease. And as we all know that valvular heart disease may cause or aggravate heart failure. And patients with heart failure and concomitant valvular heart disease constitute a very high-risk population. And all patients should receive optimal medical therapy, or what we call a guideline-directed medical therapy, and care must be taken in using the valve dilators in patients with severe aortic stenosis in order not to cause hypotension. And we have to keep in mind that valvular heart disease is a mechanical part, and ideally it warrants a mechanical solution. And here comes the role of the heart valve centers and heart valve team. The main objective of the heart valve center is to provide the best quality of care for such patients. And the requirement for these heart valve centers is a multidisciplinary teams, including a heart surgery, interventional cardiologist, non-interventional cardiology imaging, as well as anesthesiologists and other doctors like geriatricians and other specialists we may need in such patients. And this center should have a high volume and excellent in imaging as well as percutaneous intervention, as well as surgery. Let's start with patients with aortic stenosis, and as we all know that aortic stenosis is the most common primary valve disease leading to surgery or catheter intervention in Europe and North America, with a growing prevalence due to the aging population. And this is a natural history of patients with aortic stenosis that starts with a latent period with no symptoms at all, and after that, symptoms starts. When symptoms starts, the survival of the patient starts to decline, and patients with heart failure, the expected survival is only 2 years. The main concern in patients with severe aortic stenosis and reduced ejection fraction is the low flow, low gradient aortic stenosis. By low flow, low gradient aortic stenosis means that the valve area of less than 1 centimeter, LV ejection fraction of pressure gradient denoting a moderate aortic stenosis of less than 40 millimeter mercury. So, in such individual, low-dose vitamin stress echo is very important to differentiate between patients with what we call pseudo-severe aortic stenosis and those with true severe aortic stenosis, as well as evaluation of the contractile reserve in such patients. And this is the algorithm we follow in using the vitamin stress echo. First, we have to assess for the contractile reserve by estimating the stroke volume. And if the stroke volume is increased by 20% or more, this means that these patients have a very well contractile reserve. Second, to look at the mean pressure gradient as well as the aortic valve area. And if the mean pressure gradient exceeds 40 and the aortic valve area is still less than 1, this means a true severe aortic stenosis, and in this condition, a valve replacement, either surgical aortic valve replacement or TAVI, will be indicated in such patients. On the other side, if the contractile reserve is good and the mean pressure gradient is less than 40, the aortic valve area exceeds 1, this means that a pseudo-severe aortic stenosis, and in this condition, conservative treatment is required. And if we don't have a contractile reserve, that is to mean that stroke volume is less than 20% increase. In this case, we have to assess the severity of the aortic stenosis by assessment of the degree of calcification of the aortic valve by using the multi-slice CT. And if the calcium score is less than 650, in this case, we can consider this patient a pseudo-severe aortic stenosis, and again, a medical treatment is required. And if the calcium score is more than 1,650, in this condition, we can consider this patient true severe stenosis in aortic valve replacement, either surgical or transcatheter is indicated. And this is the classical low-flow, low-gradient aortic stenosis with reduced ejection fraction, means that an ejection fraction of less than 40%, mean pressure gradient of less than 40, denoting a moderate aortic stenosis, and the aortic valve area of less than 1 centimeter, denoting severe aortic stenosis, stroke volume index of less than 35, and the presence of left ventricular dilatation as well as reduction in the ejection fraction. And this is an example of patients with low flow, low gradient aortic stenosis, and his resting echocardiography showed stroke volume of 53, an LV ejection fraction of 40. The mean pressure gradient is only 29, and the aortic valve area was 0.77 square centimeter. And with the vitamin stress echo, the stroke volume increased from 53 to 73. The LV ejection fraction increased from 40 to 50. The mean pressure gradient increased from 29 to 52, and the aortic valve area is still the same of 0.75. And actually, this is a case of true severe aortic stenosis, and in this condition, aortic valve replacement is indicated either surgical or transcatheter. This is a second case of a patient, the same low flow, low gradient aortic stenosis, and His resting echo showed a stroke volume of 34, ejection fraction of 15%, mean pressure gradient 12, and aortic valve area of 0.85. And with dobutamine stress echo, the stroke volume rose to 46, LV ejection fraction rose to 25, but the mean pressure gradient still 13, and the aortic valve area increased to 1.2 square centimeter. And actually, this is a classic case of pseudo-severe aortic stenosis in which conservative treatment will be the preferred choice as regard managing such patients, and no role for aortic valve replacement in such patients. A decision making as regard aortic valve replacement in such patients between surgical intervention and TAVI based on the risk score. We use either the STS score or the logistic Euro score that classify patients into low, intermediate, and high risk. But the pitfalls of these scores is that they don't include important points like frailty, chest radiation, or the patient are very important factors decision-making process. So the choice between TAVI and surgical replacement, in general, surgical aortic valve replacement should be favored for patients with low risk as assessed by STS score or Euro score, as well as no other risk or technical factors not included in this risk score, such as frailty, porcine aorta, or sequelae of chest radiation. And also, surgical aortic valve replacement should be favored in patients who have associated cardiac concomitant surgery, some anatomical and technical considerations favoring surgery, such as unsuitable aortic root anatomy or low coronary height that make closure of the coronary arteries is very high during TAVI. The TAVI is recommended definitely for patients who are declined from surgery, and it's a class 1 recommendation, and also they are indicated in high and intermediate risk patients, and now we are moving towards low risk patients to have such TAVI. Don't forget balloon valvuloplasty and balloon aortic valvuloplasty may be considered as a bridge to surgery or TAVI in unstable patients who cannot tolerate either surgical aortic valve replacement or TAVI. The second important point is patients presenting with aortic regurgitation and heart failure. And these are the main phenotypes of causes of aortic regurgitation. Aortic regurgitation can be due to aortic root aneurysm, tubular ascending aortic aneurysm, or isolated aortic regurgitation. And this is the algorithm based on the European Society of Cardiology, the management of patients with aortic stenosis. If patients having severe aortic stenosis and he has symptoms, definitely surgery is indicated. And if the patients have severe aortic stenosis and they don't have symptoms, but the ejection fraction is 50% or less, LVN diastolic diameter is 70 millimeter or more, or LVN systolic diameter is 50 millimeter or more, in this condition, again, surgery is indicated in patients with severe asymptomatic aortic regurgitation with impaired LV systolic function. To summarize, aortic regurgitation, severe aortic regurgitation in patients who have this disease, valve repair or replacement is recommended in all symptomatic patients and in asymptomatic patients with resting LV ejection fraction of 50% or less who are otherwise fit for surgery. Let's go to the mitral regurgitation, which is a very important topic and very important part, because in Europe, mitral regurgitation comes number 1 after aortic stenosis as frequent valve disease requiring surgery. And as regard mitral regurgitation, we have either a primary mitral regurgitation, we call it degenerative mitral regurgitation due to rheumatic heart disease, for example, like we have in Egypt, congenital or some connective tissue disorders that may affect the valve, or secondary mitral regurgitation, what we call it functional mitral regurgitation, due to dilatation of the annulus, due to left ventricular dilatation, or due to ischemic heart disease or non-ischemic cardiomyopathy. And this is a very important parameter should be taken into consideration in intervention in patients with severe primary mitral regurgitation. That should be taken into consideration is because severely symptomatic patients with severe mitral regurgitation have worse prognosis as compared to those who have mild symptoms. That's why symptomatic severe mitral regurgitation is an indication for mitral valve replacement. The second important parameter that should be taken into consideration is ejection fraction. And as we see here in this curve, in a patient with low ejection fraction of less than 50%, these patients have the worst ejection fraction of 4. So this is the second parameter that should be taken into consideration when we assess indication for intervention with severe primary mitral regurgitation. Important parameters: presence of atrial fibrillation and or pulmonary hypertension, because the presence of atrial fibrillation is associated with a decreased post-operative survival as compared to those with a normal sinus rhythm, as well as in patients with pulmonary hypertension. Also, they will have a decreased survival as compared to those with normal pulmonary artery systolic pressure. And also a very important point that we always miss, in a patient with flare leaflets as a cause of severe mitral regurgitation, the usual cutoff point for LVN systolic diameter for those with severe primary mitral regurgitation is 40. In patients with flare leaflets, the cutoff point for LVN systolic diameter is 40 less, because they found that when they intervene, when they do valve replacement in a patient, at this point they have who have LVN more than 40. So the cutoff point for those with flare leaflets is 40 millimeter or less, as compared to those with other cause of primary mitral regurgitation, whereas the cutoff point is 45 or more. Also, this should be taken into consideration the left atrial size, because increased left atrial size is also associated with worse prognosis post-operatively. That's why left atrial size should also be and taken into consideration as regards the indication for intervention in patients with severe primary mitral regurgitation. And these are the types of intervention for mitral regurgitation: either percutaneous, which is edge-to-edge mitral valve repair, or even we have percutaneous mitral valve replacement, or surgical mitral valve repair, or replacement and repair is preferred over replacement in patients suitable for mitral valve repair. And this is the European Society of Cardiology guidelines for intervention in severe primary mitral regurgitation. They mentioned the same parameters I said before. Number one, mitral valve repair is a preferred technique of a replacement, and surgery is indicated in symptomatic patients, especially those with NIHA class 3 or 4 and with an ejection fraction of 30% or more. Again, surgery is indicated in asymptomatic patients with LV dysfunction. Ejection fraction LV dysfunction in patients with mitral regurgitation is considered an ejection fraction of 60% or less. So 60% or less in a patient with mitral regurgitation is considered an LV dysfunction. Again, LVN systolic diameter of 45 or more. And the same parameters, as I said before, atrial fibrillation secondary to mitral regurgitation or pulmonary hypertension should be taken into consideration in asymptomatic patients with LVN systolic diameter less than 45 and LV ejection fraction of more than 60. The presence of atrial fibrillation and or pulmonary hypertension are indication for valve replacement in such patients. Again, in patients with flare leaflets or patient in the presence of significant left atrial dilatation, the cutoff point for left ventricular in-systolic diameter is only 40 millimeters. And mitral valve repair should be considered in symptomatic patients with severe LV dysfunction, ejection fraction less than 30%, or LV in-systolic diameter more than 55, refractory to medical therapy, when likelihood of successful repair is high and comorbidity is low. The same as regard mitral valve replacement, but the class of recommendation is less. It's class 2B. Mitral valve repair is class 2A. Percutaneous edge-to-edge repair may be considered in patients with symptomatic severe primary mitral regurgitation who fulfill the echocardiographic criteria of eligibility, which is the Evers criteria, and are judged inoperable or at high surgical risk by the heart team to avoid futility. To summarize, and this is the main recommendation based on the European Society of Cardiology guidelines in 2017 as regard valvular heart disease, treatment of valvular heart disease in patients with heart failure. First, patient with aortic stenosis, and the main concern in patients with aortic stenosis with impaired LV systolic function is a low flow, low gradient aortic stenosis. That's why we should use low dose of vitamin echo to assess for contractile reserve and to differentiate between severe and pseudo-severe aortic stenosis as indication for surgery. And TAVI definitely, as I said before, is recommended in patients with severe aortic stenosis who are declined by surgeon or who are prohibited by surgeon. And this is a second recommendation for TAVI is in patients who are considered in high risk with severe aortic stenosis who may still be suitable for surgery, but in whom TAVI is favored by heart team based on individual risk profile and anatomic suitability, as I said before, like porcelain aorta. And again, I would like to remind you that we are moving very fast towards intermediate and low-risk patients as regard TAVI procedures. In patient, the second part, in patient with severe aortic regurgitation, aortic valve repair or replacement is recommended in all symptomatic patients. So all symptomatic patients with severe aortic stenosis should have aortic valve repair or replacement. And in asymptomatic patient with resting LV ejection fraction of 50% or less, who are otherwise fit for surgery. And evidence-based medical therapy, as we said before, optimal medical therapy or guideline-directed medical therapy in patients with heart failure with reduced ejection fraction is recommended in order to reduce functional mitral regurgitation. Combined surgery of secondary mitral regurgitation, and secondary mitral regurgitation should be severe because there is some doubt about the mitral surgery for moderate mitral regurgitation and bypass surgery. So combined surgery of secondary severe mitral regurgitation and coronary artery bypass grafting should be considered in symptomatic patients with LV systolic dysfunction, ejection fraction less than 30, requiring coronary revascularization after assessment for viability and for angina refractory to medical therapy. Isolated surgery of non-ischemic regurgitant mitral valve in a patient with dilated cardiomyopathy, in patient with severe functional mitral regurgitation and severe LV systolic dysfunction and ejection fraction of 30% or less may be considered in selected patients in order to avoid or postpone cardiac transplantation. Come to my conclusion, although the current epidemic of heart failure in developed countries is chiefly attributable to coronary heart disease and hypertension, don't forget that valvular heart disease remains responsible for a significant proportion of cases. Valvular heart disease is a mechanical problem, and ideally it warrants a mechanical solution. The art and science of managing valvular heart disease consists of determining the optimal time for surgery, and this is a very crucial point for us, is the optimal time before having a worse outcome post-operative. Once heart failure has occurred, valvular heart disease is associated with a dramatic worsening of prognosis, and patients with heart failure and concomitant valvular heart disease constitute a very high risk population. The prevention, prompt recognition, and appropriate treatment of heart failure in patients with valvular heart disease are of utmost importance. Don't forget the role of heart team in the decision making. So in patients with heart failure and valvular heart disease, either primary or functional, the whole process of decision making should be made by multidisciplinary heart team with a particular expertise in valvular heart disease. We have to have a heart valve center and a clinical cardiologist who is specialist in valvular heart disease, as well as structural cardiologists, structural interventional cardiologists who also experience in valve intervention. And the heart team should include a clinical cardiologist, a heart failure cardiologist, cardiac surgeons, a structural valve interventionist, imaging specialists, anesthesiologists, geriatricians, and intensive care specialists. Thank you for attention.
Thank you, Professor Nabil Farag, for this comprehensive talk about valvular heart disease and heart failure. Really, I have one comment and two questions. First, there have been recent publications about the prevalence of amyloid heart disease in patients with low flow, low gradient aortic stenosis, and the results of TAVI or SAVR in these patients is suboptimal because of the presence of amyloid cardiomyopathy. The question is, what are you going to do in patients with asymptomatic severe valvular aortic stenosis? And the second question, I couldn't understand when to use the CT calcium score of the aortic valve for decision or deciding about the need for intervention.
Yes. It's a very good question, Dr. Mahmoud. Thank you for this. I will start with the second question as regard using calcium score to assess severity of aortic stenosis in patients with aortic valve disease, specifically in patients with low flow, low gradient aortic stenosis is assessed by low dose of vitamin echo. In such patients, to differentiate between pseudo-severe aortic, true severe aortic stenosis can be done only by using multi-slice CT to assess the severity of calcification in the aortic valve. As I showed in that if the calcium score of the aortic valve is more than 1,600, and this is considered a severe aortic stenosis, and in this condition, valve replacement is indicated, either surgical or transcatheter. On the other hand, if the calcium score is less than this figure, this is considered a pseudo aortic stenosis, and conservative treatment is indicated. As regard asymptomatic severe aortic stenosis, number one, this is an actually asymptomatic, because some patients are denying symptoms. I saw many patients who are denying symptoms, or patients activities for the symptoms and come to the doctors, they said that they don't have symptoms. And patients who are elderly or patients come on a wheelchair, for example, all of these patients we have to consider assessment of symptoms in such patients will be in truly asymptomatic patients, maybe some sort of we can use the vitamin echo for symptoms, for example, assess for the ECG changes that occur during the vitamin echo and ST depression. All of this can be used as parameters for aortic valve replacement in a patient who are.
Well, Nabil, I have a comment for you on that question. Thank you very much for this wonderful lecture regarding, I insist about the left atrial volume index because it is missed in the report of the echo. Because all depending on the ejection fraction and the severity of the valve. The left atrial volume index and the guideline is missed in all our reports. So I consist. Number two, that sometimes it's difficult to assess the degree of mitral regurgitation because in surgery it is either between moderate to severe. I know some of the surgeon after coronary vascularization, they said the surgeon that mitral will be improved. How do you assess the degree of the mitral regurgitation in the presence of low ejection fraction and in the presence of after load mismatch? And in order, are you going to do the revasc and then doing TE and see if there is residual mitral, or you assess this before surgery or before intervention?
Thank you, Dr. Sokri, for this important question, but I assess it intraoperatively. I use a trans, usually we ask for a transesophageal echo during surgery, and usually they assess the severity of the mitral regurgitation using transesophageal echo before and after revascularization of the coronary arteries. And if the mitral regurgitation is still moderately severe or severe, they will go to a mitral valve repair, which is preferred over mitral valve replacement. But if the mitral regurgitation severity become less, in this condition, they leave it as such and get out the patient from the bypass. This is what we do even in our hospital. We ask for the transesophageal echo intraoperatively to assess the severity of mitral regurgitation before and after revascularization.
Magdi?
You are muted. Huh?
Dr. Magdi, you are muted.
Thank you very much, Professor Nabil, for this excellent presentation. So for the sake of time, we have to close the session. At the end of this interesting and very successful session, I'd like to thank Professor Beacom Boscoe, Professor Scott Solomon for their active participation and the great contribution to our program today. I'd like also to thank Professor Sobhi, Professor Ali Atribi, Professor Mahmoud Hassani, Professor Hani Ragi, Professor Muhammad Ramli, and Professor Nabil Farag for chairing this excellent session. And Professor Scott and Professor Beacom, you hear me?
Yes, and thank you for the opportunity to participate. This was a wonderful discussion, and I really enjoyed sharing our most recent presentations and participating in the discussion. Thank you.
Thank you very much, and looking forward to seeing you soon in Egypt.
Indeed, indeed. We all are looking forward to having face-to-face meetings.
Professor Scott.
Thank you very much for this invitation, and it was really a delightful session, and I certainly learned a lot.
And also, we're looking forward to seeing you in Egypt to see the pyramids that you mentioned. That
One day.
Yeah.
Thank you very much, Professor.